Hello, everyone. Thank you for joining. Mr. Constable. Uh, Today, Mesh brought you a new webinar about enhancing health systems research through community and stakeholder engagement. We hope you find your information useful and make good use of the time of the speakers that will be joining with us today. Today, we have Jean-Pierre Musabyimana, Javier Roberti, and Dunstan Bishanga, who they were sharing their experience with stakeholder engagement and involving the communities in health systems research. First, we're going to go through some house rules. This webinar is being recorded and will be shared on the Global Health Network. To automatically translate the speech, we have closed caption subtitles. As you can see in the bottom, there's an option to turn on the closed caption function and select your language. Due to number of participants, your video and microphone have been disabled, and the participation will be limited to the chat function and the Q&A function. You can use the chat to introduce yourself or to report any technical issues. And if you have questions, please use the Q&A function to put your question and comments. You can do those anonymously. The question will be taken either between presentations or at the end, where we're gonna have a space of answering Q&A functions. So you might want to stay to the end to hear the answers. The agenda of the webinar, this welcome and opening remarks. We're going to have a poll and a presentation from Mesh, from the one who speaks, Luis Felipe Arias Soto, coordinator from Latin America and the Caribbean for Mesh, about the role of community engagement in health systems research, a little introductions. Before the speakers will talk about the experience from their country, from Tanzania, Rwanda, and Argentina, in that order. And then we're gonna have a Q&A session with the speakers where they will answer their questions. And at the end, some key takeaways, reflections, and closing remarks. He will present the interest in today's webinars. As you can see, each country count of people that has registered to this webinar. You can see we have a very diverse public today. Thank you. So first, before I speak, we're gonna have a quick poll to kind of diagnose your interest and experience in community engagement. You can answer the poll here directly on Zoom. The first question is, do you have experience engaging with health system stakeholders, be it policymakers, healthcare providers, or funders in health system research? Second question is, do you have experience engaging patients or patient groups in health system research? And the third question is, do you have experience engaging members of the general public, community groups, citizens in health system research? As you can see the result of the polls. You can see most people answer yes to the first question about engaging health system stakeholders, but at 71%. The second question about engaging patients at 63% more, and engaging the public at 62% more. Since there's to see that most people here have experience engaging these kind of stakeholders in health research, which means that this webinar will be great for them in reflection of the past experience and future methods of engagement. So if you must further ado, we start. So hello again. We start this webinar talking about engaging health systems research through community stakeholder engagement from the Global Health Network. My name is Luis Felipe Arias, coordinator for the LAC region for MESH, the hub from the Global Health Network of community engagement and involvement. We start with a phrase from Tedros at the home. Community engagement is not just a part of global health research, it is its heart and soul. It ensures that our efforts are not only scientifically sound, but also socially relevant and culturally sensitive. Engagement is more and more demanded by research funding. The NIHR champions community engagement and involvement as a core principle of its global health research portfolio, alongside equitable partnership and local research capacity strengthening. All applicants for NIHR Global Health Research funding are required to plan and undertake active and participatory CE. Welcome also fellowship also have a mention of how have patients, advocacy group or communities being involved in developing the clinical aspect of this proposal. And more funders are joining in and asking, making community engagement a core part of the requirement for the studies, which make even more demanding for new researchers and senior researchers to learn how to do proper community engagement. And that's only the part of the funders, and we will see through this webinar part of the importance of doing community engagement and with the stakeholders in health system research. Now, state community engagement, public engagement, community, participatory science, good participatory practice. These are many terms trying to describe community engagement. On the course, you will see in different regions and different disciplines, different names for it, for community engagement. But at the core, they have the involvement of community stakeholders and the public on the research that the researchers does. So it's not only a research where the researcher is the only active participant in it, but also the people around the participants in the research, the community stakeholders. Yeah. So what is community, public, stakeholder engagement and involvement? This contested term, they have no universal definition, but it's good to have a general idea of it. So what might stakeholders be? Stakeholders can be local community representative, NGOs, research institute director, women's group lead, hospital manager, health policy makers, local chiefs and mayors. And community groups can be women's groups, school teachers, young people living with HIV, community-based orgs, nurses, youth groups, etc. These are not this list is not exhaustive, and it doesn't involve every type of research, but in every project, they might have different stakeholders, they might have different community groups relevant to the project. As you will see in the next, with the speakers talking about their experience, you will see different cases of different community groups and stakeholders involved in the research and why they were involved. But to use a working definition to have in mind, we can say that stakeholders are people who have interest in or influence over what research is done and how is it done. One might think that the researcher is the only one that decides what is done in the research, how is it done, where is it done. But actually, stakeholders have a great influence over it. It's normally it's people that either are gatekeepers of the center where the study is going to be carried over. They might be community leaders who have certain influence in what if people participate or not in the research in the first place. They might be opinion leaders whose comments are opinion consideration and taken by the community, so they have a certain influence. Whatever they say might affect how the research is done, and sometimes even if it is approved or not. And then they do have the community. We comprise the people who are affected by the research, whether they take part in it, the research or not, which normally they might also be stakeholders. We traditionally in research only thinks the participant is the only person outside the research group participating in the research. But what about the people that take care of the participants or the families or the communities they live around, which might influence the fact that the participant even choose to participate in the study, or maybe later choose not to, which have influence even if the participant choose to participate in the study and the study goes well. What happened after might be in part influenced by the community and the stakeholders. And then you have the public, who are the broader group of people which the community and stakeholders are part of, who might have a general interest in research and its role in society. Normally we say the public in the fact of why dissemination, of making the bigger, broader community know about the research, to give information to, um, and to try to avoid negative feedback if because of rumors, or because the public was not engaging in the first place. So this is it leaves a space for bad impressions. We look we normally want to give good impression about the research. If people there are interested in the research, to invite them to know more, and to make it seem the research project as friendly as possible for the community, and also get feedback on how to be more ethically done, efficiently done. Yeah. And why engage? There's many possible goals of engagement. They might be to understand the community, to promote understanding research, identify local health priorities, facilitate community input into research design. They might be to guide permission and community consent, to improve communication and consent materials, improve recruitment and retention rates, boost relationship and trust and partnership. And also it might be to share the research findings, to improve healthcare, to support young people locally to take up research. With this, you can begin to have an idea of the importance of engagement and his role in health system research, where many times the participants might be implementators in the health system. They might be stakeholders themselves. They might be institutions, but then you have the community around them. We might be the other health workers, the other institution, maybe the broader national or private health institution in the system, which might not be participating in that moment in the research, but they will be participating in the implementation. They will have a say in whether the research is converted to is implementing into a project. They might have a say whether the research can be scaled up or can even be done in the first place. As a lot of people, as you see the poll, might have experience, there is very important to gain permission and community consent, to improve communication and consent material, and also to identify and address ethical issues that might happen in the research. This is important because it guarantees the research is done ethically, that every stakeholder has a voice in the research, which is important if we strive to make changes that are sustainable and beneficial for the wider community. And also we'll see a lot of range of engagement methods. We can be community advisory board, patient advisory groups, co-designing, town hall village meeting, radio TV, social media posts. This will fall on the research team to decide to make a, a, a range of ideas to have discussion or what's the best type of engagement to do with the stakeholders, which are normally defined by who the stakeholders are and the current relationship with the team. Then normally they decide in which methods we do to engage with them. We're gonna see some of samples of this more in depth, particularly in health system research. And we see how effective it was in each project and how important it was that the resources were put on in the first place to be done. The time, cost, and effort was put on this engagement method, and there was a very strong reason to do so, and there still is in health system research. And you will see how this have a role in the type of research, in this particular case, in health system research, um, and how it can be accommodated to this field. Well, from my part, thank you. Now we're gonna go with our first speaker. His name is Dunstan Bishanga, a pro-certified public health system management expert and implementation scientist. He has over 10 years of specialist service delivery and management experience, managing and implementing large-scale integrated health projects, studies, and operations. His experience includes providing technical leadership and operations management to programs addressing maternal, newborn, and child health, family planning, malaria, nutrition, HIV/AIDS, youth and gender issues. He has successfully led complex health projects at GH Priego, Engender Health, Maristope, and FHI 360. He is a senior leader in the health discipline with training and experiential learning in various leadership and management skills. Dr. Bishanga has more than 10 years of experience in conducting human subjects research, and he has contributed to over 13 scientific publications, including as a lead author. As for ado, we give the floor to Dunstan Bishanga. Dunstan.
Thank you so much, Luis. Good morning, good afternoon to everyone. As I've been introduced, I'm Dunstan Bishanga. I work with the Ifakala Health Institute in Dar es Salaam, Tanzania. I'll be making a follow-up presentation from what Luis has just said, but this one will be more of sharing a practical experience of one of the studies that we have implemented at Ifakala, and how stakeholders' engagement can be featured. Next slide, please. Yeah, so I wouldn't go into the definition of who is a stakeholder, but I just want to make a point on two things. One, when you are determining the stakeholder, this could be a person with a stake or with the interest in your research at a design stage, implementation stage, dissemination stage, or application of your results. So when determining the stakeholders that have to be engaged in research, we should not only look at the implementation side of the research, but also expect of the use of the outcomes of that research. And as it was mentioned by Ruth, even funders and all other stakeholders are increasingly promoting engagement of stakeholders as an important pathway to achieve impact from research. So I used this framework, multi-level framework, which always is useful to determine how are you going to be applying your research outcomes. And as you may see, this framework can also help you in trying to map out who are your stakeholders. For example, if you are doing a clinical trial or a research, implementation research in a clinical settings where you have providers, healthcare providers, but again, you have the actual intervention, the tool, it could be the drug, then the pharmaceutical industries that are providing that drug could be your stakeholders. You have the patients that will take the drug, you have the providers that will give the drug, but this research is being implemented within a settings, an institutional settings, which would be a facility, then the facility leadership, the facility management would also be your stakeholders, but you have to implement your study within the context, policy frameworks of the particular country, be it the treatment protocols, be it the regulatory authorities within that particular country, and we call those structural stakeholders. You may need to engage such bodies right from the beginning if you're expecting that your clinical trial and the outcomes that will come will be approved to be implemented in a particular country. But again, as if you do expect that the findings or the outcomes of your study will be implemented in a different way, either with it will need adoption to a national policy or to the clinical practice, or it will need to be funded by a particular funder, or it will need to be sustained by a particular country, then you have to engage all these stakeholders right from the design of your study, not at the dissemination stage. So I shared this framework quickly because I can't go into details of how you do each of these, but just to make a point that engagement of stakeholders in health system research does not only look at the actors during the actual implementation, but even beyond, which could take some years. Next. So when you are determining your stakeholders to engage, you have also to find a way of segmenting your stakeholders, because involvement of stakeholders does not take this, the one-size-fits-all approach. So there's this matrix here that I think most people do know or have used before, which measures the power. We call it the power influence grid. So you have influence on one side and the power on the other side. So those most important stakeholders are those on the upper left quadrant, which is they have high power. I mean, not upper left, upper right, which you have got the high power and the high influence. Those we call them the stakeholders that you have to manage very closely. But those with high power but low influence or low interest, then those could be, you just keep them satisfied and they're happy with what you are doing and they're informed throughout the process. But then you have those who have got high influence, but they have little power or less power, and then you keep them informed because they are the ones that can help in the adoption of the findings from your study. And there is those kind of stakeholders that you don't need very much. You put minimum effort because they have little power and they have low influence. So this is very important because you have to segment and kind of try to segment your interventions in a way to make a differential efforts in how you engage your stakeholders. Next. So also in stakeholders engagement, there are levels or categories. And Goodman et al., they really provided this framework where in stakeholders engagement, we have what we call non-participation. And in most researchers, they do these first two categories, the non-participation and the symbolic participation, and they consider that to be stakeholders engagement. So in non-participation, we just do the outreach and education. They inform people about what they are doing, and they don't care what the other people say, and they have the final decision. So they don't take, it is not a two-way communication, but rather it is one way where they just say what they are doing, they keep people informed, but then the stakeholders have no say into what will happen. The symbolic participation is, which has got coordination, cooperation. They involve the stakeholders in the study design, in the implementation. They can listen to what they are saying, but they don't necessarily take their feedback or their inputs into their design and the implementation. And the most preferred level is the engaged participation, where this is the example of this community-based participatory research, where the researchers, as well as the community and the other stakeholders, they have the same say on the table, and the say of other stakeholders is considered by the researchers to inform the study. So this is a kind of range of engagement where researchers should also take note when you are saying you are doing stakeholder engagement. It should be the engaged participation rather than in the non-participation or symbolic participation. Next. So this is what I've just explained. So we can go to the next slide. So now let me go, after that background information, let me give you some example from my country and from my institution, which we have implemented very recently. So as most of people know who are maybe working in this space of malaria, WHO recommends that the use of antihistamine combination therapy is the treatment of choice for uncomplicated malaria in most settings. But then they also recommend to conduct regular monitoring of the efficacy and the safety of this first-line treatment. So Tanzania is one of the countries that for over 16 years have been conducting these studies on an annual basis, which involves children of age 6 months to 10 years on alternating sites from year to year. Now, for over 15 years that we operated until 2021, we always had a positive findings in terms of the efficacy. We had the drugs were all efficacious as well as they were all safe. Until 2022, where it was confirmed to have the astronism partial resistance for the first time in the country. And this is where now we realized the importance of stakeholders engagement and how I want to share how it helped us to navigate through the situation. Next. So this is a very summary table. Because of time, I thought I should just put some key stages of conducting research. And as you will see, my stages do not end at the report writing and the dissemination, because that's not the purpose of research. We all do health system research to improve practice, policies, and transform, improve the well-being of people. So if you have that in mind, if you have that end in mind, you always see the importance of engaging stakeholders. So in the first stage, for example, where you, as a scientist, you're preparing for your study, you are writing protocol, you are doing site selection, you are conducting site readiness on which facility you're going to use for your research. The example we had, because we knew this is something that we need to move as a country, so the ministry had set up what they call Therapeutic Efficacy Study Task Force. And this one at the Ministry of Health, the research institutions, which you have 4 of us, WHO experts, the funder, and we would plan it together. We would plan the protocol where the study should be implemented. And then we should also we had to engage the health leadership at regional, council, and facility levels. So when selecting, because when you are doing clinical trial like this, you need to have patience. So we had selected the sites where there is a high prevalence of malaria or high incidence of malaria. So we had to consult the regional leadership, the facility leadership, to see if they have the infrastructure that can accommodate, because this was inpatient treatment of the patients. So we had to consult the facilities. So that was very important, to engage all the stakeholders needed at that level. The second stage was study initiation, which we had to train the team and introduction of the study into project sites. And we had to work with the government of Tanzania as well. We had to work with the health management teams at subnational level. We had to work with the field teams that will be doing the actual research, because if they don't understand the protocol, if they don't understand the SOPs, then you're less likely to succeed in your study. But then we had to work with the community leaders and the community health workers, because to avoid loss to follow-up, because after treatment, the first treatment and the clearance of the parasites in the ward, these patients would be discharged, and they needed a follow-up to after 7 days, 14 days, 28 days, 42 days. Now, some patients would not come back for some reasons, and we are supposed to work with the community health workers and the community leaders to be able to follow up to get these whereabouts of these patients, to ensure they do complete the study at their consent. So it was very important also to engage the community leaders. For example, in Tanzania, treatment of uncomplicated malaria is outpatient. So you don't admit someone with uncomplicated malaria, but because of this study, patients had to be admitted. Now, if this understanding is not communicated to the community, then you may even cause conflicts in the families, because the husband would wonder why the mother is staying at the hospital with a kid who has got uncomplicated malaria and they have always been treated and getting back home. So this was very important to do. Now, during the recruitment now, you had to counsel the patients, the guardians, in this case, because these were children, not only the mother or the father who came to the facility, but also the spouse who was not around. Even if it was away from there, this spouse had to receive the communication. You had to work very closely with healthcare workers, the community health workers, the research teams, and they provide regular feedback to the management teams at regional and the district levels to ensure that they understand how the study is going and the challenges, because they were also providing supplies and the commodities for the study. When it came to the reporting and dissemination and the translating the evidence now from the study, you understand that as researchers, if you want your recommendations to be taken up and to policy and the practice, then you have to engage the policymakers. So we had engaging dialogue and the consultative meetings with the Ministry of Health. We had dialogue with the parliamentarians for them to understand what does artemisinin partial resistance mean, so that when we say we are going to be changing a drug, they can support that into their constituencies, they can support that into the parliament, and they can then support the government to make a change. So the regulatory bodies, like for medicines, the donor community, because they will have to buy these new drugs and support new treatment protocol, the investigators, the health managers, research bodies, international bodies like the WHO, because now when you have administration partial resistance in a particular country or in a particular region, you have to report this and share this with the broader community. So you would see when you come to apply the new evidence now, then you have to go back to the communities, because if you're changing a drug, the dosing will change, the treatment duration may change, the taste of the drug may change, and the communities have used this drug for over 10 years, so they know how to take it. So if you change the drug, for you to ensure there is adherence to the treatment, the education will have to go back to the community. So you will engage all these people again. Now, if you look at on the right column of this table, you'll realize that doing research does not only require the scientists and the researchers and the funders, it requires people beyond that, because they have a stake. Now, if you go back to our grid, the power influence grid, you would have made the analysis of how much power each of these stakeholders has, and how much influence do they have, and how do you want to engage them right from the beginning of the research. Next. So just to conclude, I would say that if you plan well to engage stakeholders in your research, they may help you, and they surely will, to formulate your research questions. So when you start engaging stakeholders right from the beginning, including, for example, you are engaging the pharmaceutical industries that are creating the drug that you are going to use. You are engaging the communities. You are engaging the health managers. They may help you to formulate your research questions so that you can generate answers which meet the needs of those who would consume your findings. It will also help you determine appropriate research methods. But then during the actual research, you'll have your activities supported by stakeholders from globally, national, subnational, and community level. And with that, you are assured that you can have successful integration of your research findings into policies, programs, and practices, which is the key objective of doing any research in health systems. So, in summary, engaging stakeholders in health system research, it informs on the best ways to design, conduct, expand, and sustain effective and equitable health policies, programs, and related interventions. Next. Asante sana for listening.
Thank you, Dunstan, for the great presentation, showcasing not only the basic of stakeholder mapping, the importance, and showing us a real case study of how did it affect the study, conducting an outcome, engaging the different stakeholders in this health system research. Now we go with our speaker. Yeah. So we're gonna go with Jean-Pierre Musabyimana, a biologist, global health research, and data scientist with a master's in science in global health delivery and a master in biotechnology. Currently pursuing a PhD fellowship in applied infection biology, focusing on malaria epigenetics. A working experience with 3 years in clinical research and evidence-based care, and 9 years in clinical laboratory systems. Earning skills in designing and conducting clinical trials, quantitative and qualitative approaches of research in different areas such as drug development, hygiene and sanitation, and evidence-based medicine. Much further ado, Jean-Pierre, you have the floor.
Yeah, thank you. So can I confirm if you can hear me?
Yes, we can hear you fine.
Yeah, so I'll take you through the experience with the current MPOX, talking about stakeholder engagement, but now this time cross-border collaboration. So as you know, Africa has been challenged by outbreaks where we have over 100 outbreaks every year of different kinds, that being viruses or bacteria. And you know, these outbreaks do not have borders, and every outbreak has its own challenges and its complexity. So which requires really high level collaboration and high level stakeholder engagement. So for mpox in particular, this has been causing outbreak from since 1958 up to currently. So we still have the ongoing outbreak. So, and when you look at the chronology of these outbreaks, you realize that its behavior and characteristic has been changing over time. So for instance, today we are dealing with clade 1b, which has its particular way of transmission as compared to the outbreak that was there in 2023, which was mainly due to clade 2b. So all these different clades of viruses present different clinical manifestations and then present different requirements for controlling them. So as it comes to controlling outbreaks or pandemic preparedness, it's a complex, there is need of complex capacity where you need many people in the engagement to be able to curb the outbreaks. So you need capacity in terms of surveillance, in terms of response, laboratory, and also very strong communication team, and also strong governance. So that's political stability, bureaucratic effectiveness, absence of violent conflict. So all these are required to successfully control an outbreak. And also you need financing, and also you need good infrastructure such as road networks, logistical capacities, and all these are the challenges actually that I will highlight as I navigate through the experience with the current mpox outbreak. So why cross-border collaboration matters? I'll give you an example of one of the borders that between Rwanda and DRC, and this is one of actually the busiest in the world. And this is South Kivu and Rusizi, which are very high, very mobile due to trade, displacement, and family ties that are linking people across the border. So health systems must really work across these jurisdictional boundaries and across laboratory networks and also data standards. So, when there's fragmented surveillance, then there is delay in response. And, we know very well that outbreaks, or particularly this mpox, doesn't respect borders. So our reach shouldn't either respect borders, should respect borders, but we should keep in mind that the problem we are dealing with crosses borders without any passport. So I'm taking you through a collaboration around two consortia that involve many institutions in Africa, so in Rwanda and in the region, so that's Burundi, DRC, Uganda, Kenya, Tanzania, and also in the Europe, around the work that we've been working together on mpox. And our goal was to provide decision makers with detailed real-time information about the burden of mpox in the region to understand the evolution, to characterize the virologic and epidemiological characteristics, as well as long-term health effects in patients infected with mpox. So the endeavor involved a lot of methods and techniques which actually cannot be found in one laboratory or in one institution. So that also highlights the need to really collaborate among institutions that deliver different aspects of research, and also decision makers, because when it comes to communication around surveillance or around outbreak, then it's the responsibility of a National Public Health Institute that needs to be informed by research. So this endeavor involved observational and interventional and study designs, and we collected data from the biological data to clinical data, and also collected some mapping related data to kind of really make sure that we have enough data that would help respond to the outbreak. So some of the methods included field sequencing. Why? Because, like I said, infrastructure is a problem. So being able to do sequencing in remote areas, you need a kind of a new strategy of sequencing. Also, this involved serology. And again, it's also, I keep highlighting that this was not only in one country, but it was involving more than just one country. So I could highlight some of the challenges when it related to this mpox. As most of you might know, it started in an area called Kamituga in DRC, where road infrastructure is a problem. So deploying like molecular techniques for the detection of the disease was a challenge. So a situation that really necessitates its novel strategies to respond to the outbreak. And these are really showing how the outbreak is really a critical situation. So some of the interventions that we did were peak trainings together with partnerships from Europe, Africa, so from different countries in Africa, different countries in Europe, to quickly establish workshops to help people learn how to respond. So this is the first training that we did on sequencing, and this was done in Rwanda. When you look at the picture, it involves a lot of people from different nationalities. So from Netherlands, from Rwanda, from DRC, from Burundi, all together trying to learn new technologies on how to respond to the outbreak. And the same here, and this is a training that involves actually the Global Health Network, C-Truly, and so these are colleagues from DRC, and we were at the border actually in Rusizi. So that's at the border of Rwanda and DRC in DRC South Kivu. And this was a training on clinical data management as also part of the response to the outbreak. So with this really partnership, we came up with very interesting findings. So for instance, this partnership was the first to identify the cause of the new this current outbreak. So we realized actually that it was, I would highlight that this was the first to identify this clade 1B lineage. And the challenge with this one is that we realized that it was not possible to detect it with the current method that was recommended by CDC, because there was some genetic deletions that would not allow this technique. So again, through the same collaborations, so a team from the Netherlands put together a new real-time PCR assay that would replace the one by CDC, and which was again validated in Rwanda and then was deployed in the whole region. As you can see, the paper we put together down here that shows how quickly this was put together through this partnership and collaboration, and then how different national laboratories would quickly deploy these to be part of their testing strategy. And this is what is being used currently in different countries. So it's in Rwanda, Burundi, Uganda, and Kenya, and also DRC. So here is also more data that we collected together and be able to put into publications. And currently we are now trying to have also work together, trying to understand different aspects of the disease, such as its epidemiology, its transmission, and also clinical manifestation, among other aspects. So in conclusion, through this very successful cross-border collaboration, we've been able to just identify the first mpox case and also prepare different studies and also train different people around virus sequencing. And also we've been able to put together a new real-time PCR assay that is being very useful in this region. And also now we've also put together disease characterization protocol, long-term effect, and also trying also to do studies on evolution and immunology of the disease. And also now we have a cohort where we are looking at mpox and in pregnancy, among many other achievements. So yeah, I'll stop here and acknowledge a very big team that was involved in this work, as you can see on the logos behind down here on this paper. So these are public health institutions, these are research organizations, these are universities from across the region and also across the globe, actually. So as you can see, we have countries here like Rwanda, Burundi, Tanzania, Uganda, all together partnering to work towards responding to this outbreak. And I will give a special thanks to the funders of this work so far. So I'll stop here, then I'll wait your reaction. Thank you.
Thank you very much, Jean-Pierre. It's a great presentation, a great example of community engagement when the context is in health, working with infectious diseases, and most importantly, one that affects many communities across many countries, which diversify and makes even more need for community engagement methods. Now we go for our last speaker. His name is Javier Roberti. He's a researcher at the Institute for Clinical Effectiveness and Health Policy in Argentina, a doctor in social science, and a researcher at the National Council for Scientific and Technical Research, CONICET, at the Center for Research in Epidemiology and Public Research, where he works on the implementation of intervention to improve the quality of antibiotic use in health centers, and he researches clinical practice implementation processes. Javier, you have the floor.
Yes, thanks. Hi, everyone. Well, I'm going to present an example of community engagement, which is a co-designing process in primary healthcare. So let me tell you a little bit about the context. Like in many other middle-income countries, Argentina's primary healthcare system has some problems in managing chronic conditions. And those problems include fragmentation of the services, limited resources, inconsistent implementation of national, international clinical guidelines. And why Mendoza, which is a province in central western Argentina with a population of about 2 million people. At the Institute, we are working in Mendoza because the Ministry of Health has been collaborating with our institute to improve the health system as part of network, a larger network of researchers we are part of, which is called Quest. So our work builds on a series of earlier studies carried out in Mendoza, funded by the Pan American International Bank, the Swiss government. And these included population-based surveys, exploratory qualitative studies with patients, providers, and policymakers, database analysis. And we then conducted a Delphi consensus process with local experts and stakeholders. Through these studies, we started to involve the community, first with focus group studies, and then with the Delphi. All of these findings gave us a clear picture of the key challenges in diabetes care. We focused on diabetes because that was a priority for the Ministry of Health. So this slide shows the three main stages of our work, that like the big picture. As I said, we began with the input phase, involving the community to understand the context. So this included all the previous studies, which helped us assess how the system was working, people's perspective on the system, what they found were the barriers. And then we moved into the model phase, where we co-designed and tested an implementation strategies. And finally, starting in a couple of months, we'll enter the trial phase, where we'll implement and evaluate the model that was co-designed before. So in the model phase, the co-design phase, our main goal was to develop and test strategies to support implementation of the diabetes clinical guideline at the primary care level. The Ministry of Health had already developed a clinical guideline, and if applied consistently, could really help improve care in primary care. But the challenge we faced was figuring out how to actually implement it in everyday practice, because in most centers in primary level, the guideline isn't regularly used or even known. So the input for this process was what we had learned. And then we brought all stakeholders together to co-design an intervention, a set of implementation strategies. And then we wanted to pilot those strategies before the large trial in the whole province. So we brought together three groups: patients with type 2 diabetes using the public primary healthcare system, healthcare professionals, including doctors, nurses, specialists, and decision makers from the Ministry of Health. We held 3 in-person sessions, each lasting about 4 hours, spread across 3 days, about 1 week, 10 days apart. So to support participation, we provided patients with a $40 supermarket gift card, the equivalent of that, and covered transportation costs for everyone. And to professionals, we issued certificates of participation, which was what they wanted. We first assessed what they needed or their preference. That was, instead of a gift card, we gave professionals certificates. So I'll tell you a little bit about the workshops to see the actual engagement that we used. In our first workshop, we focused on building a shared understanding of the current diabetes care from the perspective of all stakeholders. So we began with warm-up activities, and then we moved into role-playing. Everybody was in the same group, but then we divided into different groups, pretending as they were patients, professionals, or policymakers. The main activity of this session was the user journey mapping. So we divided the participants into these 3 subgroups and asked them to map what their care journey looked like from the point of view. So they reflected on how each stage they interacted with the system, problems they found, emotions, and possible solutions for those problems identified. So each group worked on their own journey in diabetes care. And this means, for example, that how policymakers obtain information to diabetes in the province, how they planned interventions, how they implemented them, etc. So it's easy to understand from our perspective, the patient journey, but we did the same for these other 2 groups. So as you can see in the picture, each group then documented the journey on the large sheets of paper, and then they presented the journey to everyone. In our second workshop, we shifted the focus towards barriers and solutions. So we started once again with a warm-up activity, and then we introduced a very visual activity called the sailboat exercise. So participants use sticky notes to write down all the ideas developed in the previous activity, in the previous workshop, and placed each idea or concept into a category around the boat, which the boat represented diabetes care. So the wind represented the facilitators, the ankle, structural barriers, rocks, obstacles, temporary obstacles. So we used a color for each group. So you see 3 different colors in all these sticky notes because each group had a different color. And so what we achieved is what everyone knew, that every single group had barriers facilitators, and they all wanted the same thing. So after this, we moved into World Cafe format. So participants rotated through thematic tables like access, continuity, coordination, and discussing the main barriers at each station. And the new thing here was that they proposed some potential solutions. So the barriers were those identified before, but some of the solutions were facilitators. So they had to continue working on some of the solutions. This exercise allowed everyone to contribute to each topic area and to hear from multiple perspectives because they were rotating. And the outcome of this session was a collection of collaboratively generated ideas on how to improve care. And our third and final workshop focused on turning ideas into action. So we started with a creative warm-up activity, which was quite fun. It was called Superhero Activity, in which participants imagined themselves as superheroes fixing the healthcare system using superpower. So the interesting thing was how a superpower, which superpower they chose, and how that solved the problem. So we moved into a prioritization exercise. We asked participants to assess the ideas from the workshop 2 in terms of feasibility, relevance, and impact. And this helped us narrow down the long list of proposals into a more focused set of solutions. So, and finally, we worked with a structure, with a model, a logic model, to structure these solutions. And that meant identifying the concrete steps needed for those solutions, like people responsible, necessary resources, etc. So by the end of the workshop, we had co-developed a refined list of implementation strategies. And in later sessions, we worked with professionals and decision makers to refine the logistics. So patients were not included here because the focus shifted to operational feasibility. These were more technical discussions about how to actually implement the strategies, what resources are needed, and who will do what, etc. So this is the final package, the strategies that were co-designed. A very important one, which will involve very, like the highest level of community engagement, is the community asset mapping and social prescription. That's the first one. Protected appointments, self-care workshops for patients and workshops for families and carers, professional training, improved registration systems, although it seems quite basic, but it was really necessary, and WhatsApp for engagement. So what next now? We are completing the pilot in 2 primary healthcare centers in the province. Those are the pictures of those centers. And this phase will help us assess how acceptability and fidelity to the strategies. And based on this, we'll move forward into a cluster randomized trial starting in 2 months, about 2 months, and beyond in the whole province. So what we hope is that beyond the province, we hope that this co-design approach can serve as a model for other conditions in other settings. So thank you. That was all.
Thank you, Javier. Roberti was a great example of the creativity of a community engagement method using co-designing in health research. Thanks again, every speaker for the presentation. It truly was great. Now we have many questions and comments coming in from the general public here in the webinar. We're gonna move to a panel discussion of these questions. We're going to try to answer every question we can. If we can answer your question because of time, we're sorry, but we are open to keep the discussion alive. As you have our contact for the mesh network. So we ask the speakers to turn on their cameras. The first question is to the three presenters, and it's from Nita Morar. She asks, how do the three presenters ensure that the ethical consideration and principles are adhered to, and how are these programs sustained with co-ownership by the community and stakeholders?
Yes, I don't know, I can start. Well, everything was approved ethically. And in fact, it was a little bit difficult because ethics committees are not used to evaluating this type of engagement with the community, and so they had to pay extra care, more attention to the process. And regarding the other part of the question about if it is sustainable, yeah, we were very, very careful in the co-designing process to take care that those solutions, those strategies were possible without the intervention of a research team for sustainability reasons, you know. That was one of the objectives of the process. I don't know if that answers the question more or less.
Telephone you answer, Javier, Jean-Pierre, Dunstan, any of you want to comment?
No, not on that one.
All right, thank you. Well, next question we have from an anonymous user. How would you respond to the common criticisms that community engagement takes too long and takes too many resources and slow the overall research project? Dunstan, would you like to?
Interesting comment. I think it saves time and money when people know what they're doing and they accept the intervention easily, compared to an intervention that comes from nowhere, out of the blue, without community engagement. I think that you can convince funders because of that. Now, that's all I can say. I mean, it's an issue, yeah. I see other disadvantages, perhaps, or other obstacles, not those ones, perhaps. But it's a valid question, yeah.
Yeah, I would just add to that it is resource intensive. It takes time. It takes money, and unfortunately, some researchers do not consider community engagement as part of the inputs into the research. So usually it is less costed into the budget, and by the time you realize it, you have to do this, and you don't have the resources to do it. So that's why I'm saying stakeholders engagement should be part and parcel, an integral part of the research. It is one of the key activities within the research. It should be budgeted for, and it should be communicated to the funders as well. Otherwise, you do the research in a way that it will not be taken up and it won't be supported by the community.
Thank you, Dunstan. Jean-Pierre, would you like to comment on that?
Maybe on the next, because now I think my colleagues have really given enough input to that.
Thank you. Well, the next question is from Abu Bakr. He's asked, given the relevance of community and stakeholder engagement in research and intervention, much capacity building has not been provided in this aspect across research institutions compared to clinical trainings and fellowship provided for clinicians. Why do you think is that?
That's a good question. I think because it's new. Right? It's not the usual way of. It's a shame that it's new, but that's a fact.
Yeah, so I think some training institutions, for example, for the Mumbiri University of Health and Allied Sciences, where I teach, these modules have been included into all kind of research-related trainings. So community engagement and stakeholders engagement should be part and parcel of any research training, and it should be an integral part of any study being designed. So I think all stakeholders have to recognize this new discipline into research as a core component of research, and they include it into the opportunities for research, funding for research, as well as for trainings, be it short courses or long-term courses.
Yeah, so I would also add that, so currently the way medicine or health profession is being implemented, so it's turning into a clear multidisciplinary arena. So where, first of all, people speak different languages. I mean, professionally, not just language as language, but so clinicians working with engineers working with public health professionals, epidemiologists. So this makes it really complex to communicate. So now, also including the community that is being served. If I put it in the context of outbreaks, for instance, the mpox. So what's different of mpox with other outbreak is that there's also something to do with stigma. So where contact tracing might be a very difficult thing. So if for instance, a contact does not understand why they are being chased, they will hide, So there are cases where you find that for such diseases, people do not go to the proper health facilities because sometimes, during COVID, they're being isolated, and then this involves a lot of things, including their economy and stuff like that. So that's how it makes it really, really complex. And yeah, so I think for me, even education should shift from the universities and even go to other layers of communities. So I like the idea of having these modules already, as Dunstan has mentioned. We should actually have trainings at every level, including the lowest level possible, not only formal training programs. Over.
Thank you all for great answers. Next question we have from Eka. He asked, from your perspective, what strategies are most effective in ensuring that community and stakeholder engagement in health systems research is genuinely participatory and empowering, rather than tokenistic, especially in contexts with limited resources?
Can you repeat that?
Maybe I can start on that. I said from the power influence grid, the first thing you have to do your stakeholder analysis to determine the stake they have, how much power, how much interest, or how much influence. From there, then you determine the engagement approach. Now, the core principle for the effective engagement or participatory engagement is to make sure that it is a two-way traffic, that you communicate as investigators and you listen from the stakeholders and they take into account their inputs into your research processes as well as dissemination. So once you have that, and of course, it is very important to train your research team on stakeholders engagement, because you as an investigators team, as a researcher, as a PI, you may have this concept as part of your research, but then the team that is implementing your activities does not get it, and then they may not honor it during the implementation, and you may violate your protocol, which may cost you at some point.
That's great. Thanks, Dunstan. Javier or Jean-Pierre, want to comment on that? How to make community engagement truly participatory?
Oh, yeah, it's a big question. With creativity, I think you have to find a way. But yeah, convincing stakeholders. I was answering questions there in Q&A, and one of the questions now is, yeah, how to encourage that. First, you have to convince, in our case, for example, the Ministry of Health, not the funders, because that was part of the grant. You know, it was a compulsory, let's say, in some sort of way. So that the funders expected that, so there was not a problem there. So we had budgeted for that. But then we had to have many meetings with the Ministry of Health, and they liked the idea very much. It was new for them too. And then, yeah, work very hard with professionals, with healthcare providers, because they tend to think that is just information that we are giving, that what we are doing is informing or disseminating, and that's a big thing that we have to change. They tend to think in old ways, you know.
Great, thank you. Now we have a next question from Jana Michelle, this specifically to Javier Roberti about her co-creation experience in research. She comments that it sounds like human-centered approach with 3 phases of inspiration, ideation, and implementation. She would like you to comment on that.
Yeah, I responded that in the chat. Yeah, absolutely. I said the same thing. It's we didn't have time to present the frameworks that we used, but that was definitely a framework to guide the process. Yeah.
Thank you. So Agnes Farai asks, what do you consider as the best way to engage the general public?
I think first informing what that is, how it is useful for them. And then we, as I said, in our case, we had to use these coupons because it is not easy at the beginning. You know, people in our case, I don't know if that's the case for everyone else, but in our case, people were not very sure what they were going to expect. They thought that they were going to be participating in a workshop about diabetes. So it was quite difficult at the beginning. So, yeah, invitations from their doctors, that's very important because they trust their doctors, not directly from the research group because they didn't know us. So first we worked for 2-3 years doing focus groups, surveys, interviews in the field. So they got to know us. But then, yes, invitations had to be made by through the doctors, through the clinics.
Thank you. Dunstan or Jean-Pierre, wants to comment on that? The experience with engaging the public?
Yeah, so it all depends on the stage of the research. You may maybe don't need to engage the public at the design stage, like the whole public, if you are talking about the general public, but you could do engage some representatives, cohort groups, like to get some inputs. But then when it comes to at the dissemination stage, for example, or you want to change a practice or policy, then you need more wider engagement of the public. And this could do either you do it through interpersonal communication, which may mean going through the community leaders and getting some, champions or agents of change at the community level to do that. But also you could do it through mass media, doing like radio or IC materials or TV. So all that it depends at the stage of the research and the purpose you want to achieve. But also you look at the context, how easy can the community kind of consume the information you want to share.
Yeah, thank you. So I think I also add that it will also depend on the context of the project or the program. So, for instance, disease conditions that involve stigma, then they need a specific approach on how to engage community. Or the example that Dunstan gave with their program in Tanzania, if you want to change a new regimen, new therapy, for instance, the case of malaria, because now I think many countries are now moving to multiple first line. So the way you engage that, because there's now you are adding responsibility to the community. For instance, if they are used to taking the drug like 1 day, or if now they have to take it 5 days, so it's more commitment. So now the way you engage them. And I also recognize that actually science has focused mainly on different methods of the conventional research. So, trying to look at different methods and what could be their impact and how to improve them, but very little focused on different methods of community engagement, which method has this kind of impact, which other method would in this different context. So, we need to really acknowledge that there's a huge gap that needs to be filled in that context.
Thank you. So another question, how do you clearly delineate or separate from stakeholders and community members being participants of the study, usually via interviews and focus group, versus the community engagement strategy of the project?
Sorry, that again. What's the difference between
the stakeholders and community members being participants of the study, being interviews or focus group, versus the community engagement strategy of the project?
Okay, now I guess there were different stages. The first one, we conducted focus groups and interviews just to know their experience, what they had to say about that, how they used the system, etc. So, and that was input for the co-design. In the other phase, the co-design, they actually designed through different activities the strategies. They said, well, this will work, this won't work, and they had the opportunity to confront even sometimes policymakers that were convinced that certain policies and measures were being implemented in the fields, in the clinics, and were not, in fact. So it was a different process. So the first one was information gathering, let's say. We learned about the community and the system, how they use the system, and the other one was just to design the strategies.
So I would also add to that, like when we're talking about community engagement or the stakeholders engagement, you are considering the socio-ecological model, where your research could be working with individuals, but then these individuals are surrounded by different spheres of influence, from family level, community level, organizational level, policy frameworks. So your participants are individuals, and this could be the subset of a broader community. But looking at the ecological framework, the stakeholders are everyone else surrounding those individuals. So if it is a policy framework, you may talk to the minister about your study, and this minister will never even be at the study site where you are. But you understand if anything blows up when it comes to the ministry, at least they're informed of what you are doing. But then, like the study we had, our participants were children 6 months to 10 years, but we had to talk to the father who even didn't bring the child to the clinic, because this is a gatekeeper, is a person who can say, take this medicine or don't take it. So I think that's the difference where it comes from.
Yeah, thank you, Dunstan. Jean-Pierre, do you want to add anything on that? Great. Great. We're reaching the end of the Q&A section. Let's see. Any other questions? Yeah. So there's a question from Mario Dimabilis. What elements of community engagement are in play in conducting successful health research through community and stakeholder engagement?
Sorry, what?
What elements engagement? Can you hear me right? Okay. What elements of community engagement are in play in conducting successful health system research through community and stakeholder engagement? Which are the core elements in place?
So maybe if I can give it a first shot, I'm not sure if I understood it well, but in community engagement, always you start with the community, stakeholder analysis. If you want to engage the stakeholders, you start with the stakeholders analysis. And the stakeholders analysis, you're looking for the stake that is, a particular group or a particular individual has, or a particular organization you do have. So in that case, the elements as you talk about, the power, the role into that community, the vulnerability of the particular stakeholder, the interests of a particular stakeholder, the contributions, the expertise, the knowledge. So when you are doing stakeholder analysis, you look into all these dimensions, because then you can determine how you can approach each category and how they can be part and parcel. For example, if I'm talking to the medical officer at the district level, the level of engagement of a medical officer is different if I'm talking to the community leader. Even if so, I have to understand this is a clinical trial. The level of details I'm going to give to the medical officer of the district should be technical enough for him to understand what it is. You talk about the safety of the drug. You give some evidence of previous studies that have been done. But then when you go to the community member or the community leader, you'll tell this drug has been approved by the country, by the authorities in this country. It is proved to be safe and it does not cause any harm. You don't need to give the p-values and the safety measurements and all that, because then the language won't be taken. So those are some of the things that you have to consider.
Yeah, so also one thing that I would also say, especially, again, talking in the context of cross-border, it's something to do with culture. So there's culture as a broad term, but there's also culture as micro details. So if you are engaged in community, it's good to first learn more about their cultures, what they believe, small details of the culture, because sometimes when things do not align with the culture of somebody, then it's very, very difficult to engage. Also, another element that Dunstan highlighted is power. So when you deploy a technology, then it's good to first know who has power to make this happen. And also now information. So, currently most of the products that have been used during outbreaks are more of investigation. So knowing how to share information around those products, and also to share clearly what's not yet known about those products. That's really very, very important. So yeah, information sharing, culture consideration, and power mapping, knowing who has power over what. So those are really, really key elements.
Well, thank you all for answering these questions. They were great. There are many more questions, but we have little time, and many of them warranty their own webinar session, really. Thanks again. Now we go to the closing remarks. We thank again for everyone for getting in the webinar at the end. We talk here in the Global Mesh Network. We try to get experts in community engagement together with any person that is involved in this, in community engagement. We normally multidisciplinary effort. And that's why we do these webinars, community capacity building, and try to disseminate work on our webpage, a Mesh Slack, and a Mesh TSN, to disseminate work and try to connect the network and make it more known. Also, we have resources available, as some of them have been shared in the chat, about how to effectively plan a community engagement strategy, how to lead and create a community advisory board, and also we have available a community engagement course online, completely free, of different models, with the accreditation of NIHR Institute. Again, we have come to the end of this webinar. We hope it was of your liking, and also we can follow up the discussion later on between our networks, and we want to have a real impact in health system research globally. So we promote, we ask of you of sharing this with your partners, your colleagues, and keep raising a voice of the necessity of community engagement in health research. That'll be all. Thank you.
Thank you, everyone.
Thank you.
All right. It was really great to see such an active discussion. Thank you all for your kind words at the end. We will end this webinar now. All the best. Until next time.